Welcome to the Explainer. Today we're diving into an intense, rapid-fire review session for what I know is one of the toughest exams out there, NORCET. We're going to cram the absolute must-know facts for obstetrics, so let's get right into it. Alright, let's get straight to the point. Our goal here isn't just to passively learn, it's to actively drill the high-yield, gotta-know facts from obstetrics that are pretty much guaranteed to pop up on your exam. We're going to be recalling what you already know and really cementing it in place. So first up, we're starting with the hormone playbook. I'm telling you, if you get these right, the entire cycle of reproduction and pregnancy just clicks into place. Let's jump in. This is a classic, a one-liner you absolutely have to know cold. What single hormone is the one that kicks off the release of the egg? And the answer is luteinizing hormone, or LH. But here's the key takeaway for your exam, and listen closely. It's not just the presence of LH, it's the surge. You have to remember that word. That sudden, dramatic spike is the direct trigger for ovulation. Now, here's a fantastic clinical tie-in that examiners just love to test. Notice how LH and HCG are functionally so similar. They both support the corpus luteum. So what does this mean in the real world? In fertility treatments, we can actually use HCG as a stand-in for an LH surge to trigger ovulation. A lot of times just because it's cheaper and easier to get. You need to remember that clinical link. Okay, this one is a classic point of confusion. What is the very first signal that tells the body, okay, time to start making milk? Is it the baby suckling, or is it something else that happens the instant the baby is born? And the answer is the sudden drop in placental hormones. Think of it like this. All through the pregnancy, high levels of estrogen and progesterone are basically putting a brake on milk production. The second the placenta is delivered, that brake is released, and those hormone levels just plummet. That is the green light for prolactin to kick in and start making milk even before the baby's first latch. Alright, let's switch gears from hormones to the numbers game. Section 2 is all about those critical timelines and values you absolutely positively must have memorized for the exam. This number right here. This is the time from the start of that LH surge we talked about to the moment of ovulation. Just commit it to memory, 32 to 36 hours. If you see this range on the exam, it's almost certainly the answer they're looking for. This slide maps out the incredible journey of the first week. You have got to know this sequence cold. So let's walk through it together. Day 4, the morula enters the uterus. Day 5, it sheds its protective shell. That's the zona pellucida. This is so important because that's what allows implantation to begin on day 6. By day 10 or 11, the whole process is complete. Okay, on to section 3, decoding the ultrasound. Now, you don't need to be a radiologist, but you do need to recognize these key signs. They are classic image-based questions. Now pay really close attention to the wording here. Seeing a gestational sac is a good start, right? But it doesn't 100% confirm the pregnancy is in the right place. So what is the first definitive structure that tells you for sure this is an intrauterine pregnancy? The answer is the yolk sac. And here's why this is so critical. An ectopic pregnancy can actually create something called a pseudo-gestational sac, which can totally fool you. But only a true intrauterine pregnancy will have a yolk sac inside of it. The moment you see that yolk sac, you are 100% certain the pregnancy is where it's supposed to be, in the uterus. Alright, this is a super high yield area, but it's also really easy to confuse the double signs. Let's break them down so you never mix them up again. First, the double bleb sign. That's the yolk sac and the amniotic sac together. A great sign confirms an early pregnancy. Next, the double bubble sign. This is totally different. You see this later in the fetal abdomen, and it's a marker for duodenal atresia. And finally, the double decidual sign. That's the 2 rings you see around the gestational sac. Another good sign of a healthy early pregnancy. Make sure you can tell these 3 apart. Alright, finally, section 4, clinical crisis management. Let's take what we've learned and apply to some scenarios you will absolutely see, both on the exam and in your practice. So here's a really common scenario. A mother comes in with pregnancy-induced hypertension and the fetus is measuring small. Right away, you're suspecting intrauterine growth restriction, or IUGR. And at its very core, what's the problem here? It's a problem of placental insufficiency. So the huge question becomes, how do you objectively figure out how the baby is actually coping? What is the single best investigation to guide your decision on when to deliver, to decide if that baby is actually safer out than in? The answer is the umbilical artery Doppler. This is your single most important tool for managing IUGR. because it directly measures how well the placenta is doing its job. If you see a high resistance in this artery, that's a massive red flag. It means the placenta is failing, the baby isn't getting enough blood, and you need to start thinking about delivery fast. Okay, next question. A lot of maternal conditions like HIV or active TB are relative contraindications to breastfeeding. They can often be managed, but what is the one absolute, no exceptions, non-negotiable contraindication? The answer is galactosemia, and the critical thing to notice here is that this is an infant condition, not a maternal one. The baby has a metabolic disorder and simply cannot process the galactose in milk. It can be life-threatening. This is the only absolute contraindication to breastfeeding. This slide lays out the essential pathway for Down syndrome testing, and you gotta know it. Just remember, it's a two-step process. First, we screen. Screening just calculates the risk. It's all non-invasive stuff. If that risk comes back high, then we move to a diagnostic test. That's what gives us a definitive yes or no answer. And for the exam, you have to know the timing. CVS in the first trimester, amniocentesis in the second. And let's end on this piece of exam strategy because it's so important. It's the 80-20 rule. 80% of your questions are going to come from 20% of the syllabus. Please don't get lost studying rare, obscure syndromes. Master these high-yield core topics we covered today. That is your most efficient path to success. And that's our rapid review. Before you go, I want you to pick one concept we covered today that maybe felt a little shaky. Was it the double signs or maybe the timeline? Whatever it is, go review it one more time right now. Lock it in. Good luck with your preparation. You've got this.